All right, guys, I'm gonna start in like 5 minutes, a little less than 5 minutes. My reviews tend to be very quick, but I'm gonna try to make it a little longer. But I like to just go through the material with you guys and so that you guys understand it. If you have any questions while I'm going through it, just say, stop. Can you go over it again? Or what do you mean? Or anything like that. Because that's the best way for you guys to review. I just have had feedback from students saying that they appreciate that I just get to the point of it and it's not like this conversation back and forth. But if you guys want that, then you just let me know, okay? I'm going to use the PowerPoint that is available to you guys, that's on the exam review, and I'll go through it and highlight what I think is important. If anybody wants to meet with me prior to the test, just do one-to-one review. I can do that with you. So just let me know and we'll schedule that. Um, you guys don't have to have your cameras on. You can have them on if you want, but you don't have to have them on. Feel free to just listen or take notes or whatever. And we're going to start in just a few minutes, okay? So that was just my little prep, and we'll
Is
do
it
our review.
the exam two blueprint or the prep?
Huh?
Which the PDF, which one was it? The blueprint or the prep?
No, the prep. Where did you get a blueprint?
It says exam blueprint and PowerPoint.
Oh, all right.
I
Well,
know
that's
Miss
good.
McBride class, she gives us a blueprint.
Oh, that's something new though, right?
I believe so.
Yeah, I think it's new. All right, so you access both of those, okay? Those are both good resources to have. And let's just wait a couple more minutes to see if anyone joins and then we'll start.
Oh, the blueprint, it just tells you the topic of the things, I guess.
Yeah, it has the topics on there, but I think that was a good one of the professors had a blueprint, and she thought that was helpful. So I think that's why we're having them now,
Okay.
because one of the teachers thought it was a good tool or whatever. All right, and some of what we're going to go over tonight may be a review for you of stuff that we've done for a previous test, but let's just we'll start in a couple minutes. This is where we're going to start though, with cultural competency and ethnocentrism.
And this the content for exam 2.
Mm-hmm. This is kind of a review, like I just said, from exam one. I know this was on exam one, but we're just reviewing it because you may see it pop up again.
Oh,
It's kind of a concept that you guys should be really familiar with and comfortable with for every class that you take. Okay, when we look at cultures and cultural competency, This is where we're going to start. Ethnocentrism is when we think everything we do is correct. Is the way of doing things. So that's when you think about yourselves. We have cultural competence, which is how culturally prepared are we to work with another community, and then cultural relativism as well. All right, we looked at conditions that will impact the birthing, the labor and delivery process. So we have pre-gestational, which is before you're pregnant, and then we have gestational. Okay, remember that we have an increase in insulin resistance in the second and third trimesters. We know that demand decreases quickly after delivery. And Humulin is the most common medication used in pregnancy, I think is what that's supposed to be. How do we care for our diabetic patients? We make sure we do daily blood glucose testing. We look for target levels, which you can see in your book, where our diet is going to be like diabetic or pre-diabetic, healthy carb intake, like our brown carbs versus our white carbs. We're going to be exercising after meals, particularly important with our diabetics, that they're surveilling the fetus, right? They're detecting how often is it moving. We'll have NSTs, which look at the fetal heart rate, and ultrasounds. Here's some risks that we come across with our fetal and our neonatal risks. So we have a history or a likelihood of hypoglycemia on our neonates because they've had this insulin in their system and now their body's supposed to kick in. We also have some macrosomia because that baby's getting tons of extra nutrients to it. We can have congenital anomalies if we have poor glucose control in the first trimester. With our maternal risks, we have macrosomia with when you have poor sugar control. You might have preeclampsia with diabetes, infection, and ketoacidosis, which we know is going to be have a lower threshold during pregnancy than it does otherwise. Cardiovascular disorders, another area that we looked at. It causes for a high risk pregnancy, of course, because the heart is working double now that we're in pregnancy. So signs and symptoms of stuff not working well: shortness of breath, fast heart rate, and swelling. So we look for signs of generalized edema, shortness of breath, palpitations, wetness in our coughs, because there could be fluid. Avoid straining and constipation. We speak about when you're pushing during the labor and delivery process, you do it open glottis, so it's not closed mouth, and you're not straining yourself as much. And manage discomfort. You're going to see our cardiac patients are going to be really watched very closely. Preeclampsia, we know, is going to be our high blood pressure during pregnancy. And it's really from the placenta. The placenta is the problem. So once it comes out, this stuff should go away, but sometimes it doesn't. It's because we have increased peripheral vascular resistance. So those vessels aren't as wide open as some others. And so we see an increase in blood pressure. So with preeclampsia, you can remember proteinuria, which is protein in our urine, which is going to be greater than 0.3 on a dipstick. A high blood pressure, meaning it's going up, a rising blood pressure, and then sudden weight gain and swelling in the face and hands, okay? Oftentimes we'll see pitting edema. Remember, that's where you see swelling. When you put a finger on it, it stays in, okay? What we look at, I'm sorry, I just need to pause for 1 second. Okay, sorry about that, guys. All right, so we're looking at our preeclampsia. So we have the high blood pressure. We have what are our diagnostic criteria for it? So we're going to see, do we have low platelets? We look at our renal insufficiency, so proteinuria, right? impaired liver function, so we'll see elevated LFTs, right upper quadrant pain, so we always assess for this. We're going to have edema, possibly pulmonary edema with severe features. We're going to see those visual symptoms like a headache, blurry vision. Risk factors for preeclamptics are going to be obesity, gestational diabetes, and hypertension. HELLP syndrome is when we have this high blood pressure and it gets worse, okay? So it's HELLP, hemolysis, elevated liver enzymes, low platelets, okay? Right upper quadrant pain, it's going to be when that blood pressure is really getting to the rest of our body, okay? So we're going to check for our deep tendon refluxes, and we're at increased risk for seizures. We're going to have proteinuria. So what they'll do is they'll watch your protein you collect urine for 24 hours and see how that comes out with your ratios. So what do? We use mag sulfate to treat or prevent our seizure activities with our preeclamptics. So it goes via the mag sulfate goes by IV. Our loading dose is 4 to 6 grams, and then we stay in a maintenance dose of 2 to 3 grams per hour, or at least 24 hours, okay? And we'll keep on this until the preeclampsia resolves or the placenta comes out, and we see if it resolves, okay? So we want to make sure that it's being excreted, the mag sulfate, so you don't get toxic with it. We're going to assess our in and our out. Some signs and side effects of it, which is not uncommon, is going to be you feel warm, flush, sweating, decreased uterine tone. So sometimes they're on mag sulfate, they're being induced for labor, but they contraindicate each other. The baby gets tired, so we want to make sure we put them on the side, the left side. We're going to monitor blood pressure every 15 to 30 minutes. We're going to make sure that we listen to lung sounds. We're going to make sure we look for respirations, for INOs. Our antidote for our mag sulfate is going to be calcium gluconate. All right, eclampsia is now, you've had preeclampsia, which is the high blood pressure part of it. And eclampsia is the seizure or coma that a preeclamptic woman can go into. So what do? It's a seizure. So it's going to be tonic-clonic. We're going to have airway and safety. You don't leave the bedside. Fetal tracing is going to be impacted. They're going to have some maybe like low heart rate, deceleration, but because they're having some hypoxia event. Okay. Any questions about preeclampsia or mag sulfate? I think we go back to it towards the end, but anyway. We have hemorrhagic disorders. So those are ones that are going to cause bleeding for some unknown reason. We have molar pregnancies where you have no fetus or placenta, okay? So it's just cells that develop. And an ectopic pregnancy is when it's in the tubal, abdominal, or ovarian area, and then you'll see that you'll have that abdominal pain and delayed periods, and you treat that with methotrexate or surgery if you have to go in and take it out. All right, early pregnancy, if you have spotting, not always unusual, not always detrimental, but can be. So spontaneous abortion is before the age of viability. Does anybody remember age of viability?
20 weeks.
I got something in my nose.
No, not 20.
I know.
When can a baby survive outside the
After
uterus?
24. After 24.
Good, 24 weeks, good. So spontaneous is going to be before 20 weeks usually, but 24 is viability. And so you may have just, some vaginal bleeding, some backaches, cramping, okay? And we look at our cervix and how, is it weak or is it strong? We may have cervical insufficiency, like a cervical weakness. So you're going to really keep an eye on those patients that are 3 or more preterm births or second trimester losses. We look at our cervical length. Cerclage is when you go in and you put a suture in, as you can see in this picture. So you put a suture in to keep it closed. Okay. All right, placenta previa. These are going to be two big ones, previa and abruption. Okay, so our previa is when the placental is going somewhere near that os, so somewhere near the bottom. And so what we need to make sure we see is that they are delivered by C-section, and we'll show this picture a little better so you can see the placenta down here. This is the placenta right here, so you can see it's right by the opening. So once that cervix dilates, they're going to bleed out. So you're going to do a C-section. Be very careful because you can have bleeding profusely. So you're going to do a type and cross. Make sure they have it there with them. All right, and then abruption is when the placenta abrupts or rips away. And so what can cause this is hypertension, cocaine. With sharp abdominal pain and tenderness, you're going to be very cautious here. This is going to be dark red bleeding, okay, as opposed to the bright red, because that previa is right by the os. So as soon as it starts bleeding, it's going to be fresh blood, and this will be a little darker. All right, so when we compare the two, we look here. Placenta previa is oftentimes not painful, and nothing's going to happen. They just have a fundal height that's going to be raised up because they have bleeding going on. And then when you abrupt or the placental breaks apart, and they say break apart because that's to signify the pain that comes with it, and you're going to have a rigid abdomen, and it'll come on super, super duper quickly. This one, the placenta previa, you can watch for an ultrasound. This one just happens.
So with the abruption, the placenta abruption, is that the one with can be caused by trauma as well?
Yeah, it's whatever causes a premature rupture of a premature separation of the placenta. So this placenta separates.
Okay.
So that's when whatever can cause that. So lots of different things can cause that. Sorry about that. All right, we then have DIC, which is a big bleeding disorder that occurs during pregnancy. It's triggered by a plastin in the blood cells. The most common cause, okay, of DIC, when DIC comes, it's going to be coming out of everywhere. Okay, so I want you to remember that. DIC means everything's coming out of everywhere. So you're going to see bleeding in the mouth, bleeding anywhere that you could see bleeding, you will see. So you'll have bleeding in the urine. Okay, you'll have tachycardia because everything's the fluid, it's going to be a fluid imbalance. So the only way to fix it is to correct whatever's causing it. Okay, so it's a major, major one. We look here at trauma during pregnancy, like motor vehicles, falls. What do you think can happen with a fall or a motor vehicle when you're pregnant? What happens maybe? It might be traumatic.
Abruption?
Yeah, the belly gets hit. So anything can happen there, right? And so what we always do is if there's any trauma at all, we're going to monitor that fetal heart rate for anywhere from 4 to 24 hours, okay? And make sure that we don't see any signs of that abruption. If doing CPR, you just place the uterus like you're showing here to the left lateral, okay? And if you're choking, you go above that uterus because you don't want to squish that uterus, pull at it. All right, hyperemesis is really just really nauseous during pregnancy, excessive vomiting, can't really eat anything. So what do? You lose weight, you get imbalanced. So what we do for this is anti-emetics, IV hydration, monitor our INOs, make sure we do bland diets, right? High protein after sweets. Cold is oftentimes better than warm because warm will cause more of that nausea feeling and vomiting. And so you're going to alternate and try to keep these people hydrated and not dehydrated. All right, preterm labor we know is less than 36 and 6 or 37 weeks. Oftentimes we give prophylactic progesterone if we have a history of preterm labor. We give different medications like terbutaline, indomethacin, to stop that uterine contractions. We're going to give antibiotics because they help with preterm labor. Betamethasone we give for the baby's lung maturity. And mag sulfate has been seen for neuroprotection, so that's for the brain. All right, post-term is going to be greater than 42 weeks. What happens? The baby is overgrown and done. So sometimes they will have meconium past the first stool before birth, and that'll be in the amniotic fluid. They can be really big. They can have not a lot of fluid or have too much fluid. That's oligo. The placenta gets old and yucky. And you're in increased risk for meconium aspiration, which is when they take their first breath, they suck in that meconium, and think about what that does to the lungs when that happens, okay? All right, precipitous labor we talked about. It's when it's quick, 3 hours from onset to time of birth. What are some things that happen? Trauma to the baby, maternal, you can have that rupture because it's so contracting, quick. And then postpartum hemorrhage, oftentimes you'll see bleeding. Or hypotonic contractions where they don't really relax. And so you're going to see that with cocaine use, and you're going to see that with an abruption. And you also see that with uterine tachysystole. All right, induction of labor. We talked about that this last week. Chemical or mechanical initiation of uterine contractions. So elective without a medical induction, without a medical indication, needs to be at 39 weeks or above. We look at a Bishop score, which evaluates the cervix and how favorable it is. And so a score of 8 or more is considered favorable. Some of the meds we use are Cytotec, which is a little pill, Cervidil, which is like a little piece of tape, and prostaglandin gel, which is just a gel. We also can sometimes use a catheter, if you can see it right here in this picture, and that's they try to get it so that it'll put pressure to open up the cervix and cause contractions. All right, chorea we talked about in my class tonight. It's a bacterial infection in the amniotic cavity, and it often occurs after labor begins. What do we look for with infection with anyone? We look for maternal fever and tachycardia, uterine tenderness, and oftentimes the amniotic fluid will smell foul, like it'll smell funny. So what do? We give antibiotics. We do tocolytic therapy. Is contraindicated. Why do you think tocolytic therapy, which is when you stop the contractions, is contraindicated? Why would that be contraindicated? Anybody know? So there's an infection, so the baby shouldn't stay in there. That's why you don't want to keep the baby in there with an infection because it'll transfer on, okay? We looked at cesarean births. There's 2 different cuts. There's an up and down, and there's a side to side. You're most likely going to see the side to side more likely than the vertical because the vertical is much more obvious. They'll do this if they need to get into the uterus quickly. Okay. What are some risks of a C-section? Always infection. It's abdominal surgery. They can nick the bladder. They can cut another organ that's in here. Babies sometimes have some respiratory distress because their lungs aren't squeezed coming out of the vaginal canal. So you can see that. Anesthesia, they do spinal, epidural, or general. They will try to stay away from general as much as possible. Does anybody know why? Why wouldn't you do general anesthesia on a C-section? Remember, anything that you do to the mom, you do to the baby. So those babies cannot tolerate that general anesthesia for long periods of time. So it's not the first choice. It's usually emergent. If they have to put a patient out, it's usually emergent. All right, so pre-op, what do? We take labs, we give them meds, whatever they need. We put a Foley in, we shave wherever they're going to get cut. So you shave down here or up here. Intraoperative care, make sure you do a timeout. That's when you stop everybody and say, are we doing the right thing at the right time? And we have circulating and infant care in the OR. And then post-op, we do PACU, like a typical PACU. And then post-op, postpartum care, pain, intake, ambulating is what we're going to do. Okay, any questions about that? All right, so we continue on today with our review. Shoulder dystocia we talked about tonight too. It's when the head comes out and the shoulders get stuck. Okay, so it's usually a history of a prolonged second stage of labor because the baby's going to be big. You can have clavicle humerus fractures, right? Shoulder can break. What usually happens is mom's going to have bleeding after this because it's a lot of trauma to that vaginal canal. So you'll have hemorrhage and trauma to the perineum and rectum. And you can do different maneuvers that can help sometimes. So here's a picture of them. So you put pressure right there at right below the shoulder and try to push it out or flip the mom's legs all the way forward, all the way back. And that's called McRoberts. Cord prolapse. Remember, it's when the cord comes out before anything else. So that's going to be an emergent right away. So what you'll have is you have compression of the cord during contractions, or you can actually see the cord that comes out. What's the problem with that? The baby's not getting any blood flow. So what do? We stay with the patient, we have help, we glove up, and we put pressure on the presenting part so that we push up on the head so the cord doesn't get compressed, okay? And we're going to do a stat section quickly, okay? Here's some pictures, like this is where the cord could be, see, and you see the problem, it comes out first. So you can sort of, you push the head up so that you don't have compression of the cord. All right, postpartum assessments is called bubbly. It's the breast, the uterus, the bladder, the bowel, lochia, episiotomy, Homan sign, and emotions. What are we looking for in Homan sign? Remember what that's for? Anybody?
I think a DVT or
Very good. Excellent. DVT. So when you push the foot back and they have pain in that lower calf, it's positive for DVT. All right, so with our breast, we talk about the release and emptying of production, and oxytocin will be our letdown response. I'm going to skip ahead a little bit. All right, our uterus postpartum. I don't. Anyway, our uterus or postpartum assessment, you know the uterus goes down day by day by day. I'm going through this relatively quickly because I don't believe this is on our test. We haven't covered this. This should be next week, but we'll go through it anyway. Our bowel and our bladder, we're going to make sure that we have a risk for constipation. So people are afraid to go to the bathroom afterwards because they've had a laceration, right? And so they're afraid to put any pressure down there. Our bladder, we want to make sure that we're keeping that voided, that it's empty, because if the bladder is full, it's going to displace our uterus. Lochia is how much bleeding you have. And sometimes if you have excessive bleeding, then you will have hemorrhaging. Here's a hematoma post delivery, so it's a big like bruising and swelling in a big tissue, and so that's just where you can see that. Bleeding management, we'll keep that. Yeah, we didn't go through this. All right, so with our cesarean and our lacerations and our episiotomies, we're always
Excuse me, I'm
going
sorry
to
not to
assess
cut you off.
REDA, right? Our redness, our edema, ecchymosis, discharge, and approximation. We're going to
Hello?
make sure. Can somebody
Sorry.
mute?
No, I'm trying to talk to you.
Okay, somebody needs to mute.
No, I'm trying to talk to you. I'm
Oh,
talking to
sorry.
you.
Go ahead.
Everything that you just skipped, my teacher went over that, and I thought that that was supposed to be on the exam. So now I'm confused.
Okay, so I have to take a look at the exam again. They change from quarter to quarter, but it's really postpartum assessment, and so I can go over it a little slower. Would you
No,
prefer
no,
for
no,
me to
no,
do
no,
that?
no. That's not what I'm saying. I'm just saying when you said that it's not gonna be an exam, I was like, what do you mean? Because
Okay, if your teacher said it's on the exam, then it's on the exam. Okay,
oh, okay.
every teacher makes their own test.
Oh,
My
okay.
class did not go over it, but it is something that they should be aware of. Postpartum
Okay.
bleeding and episiotomies and all this. This is postpartum care, but it depends
Oh,
on the questions that are picked by your professor.
Gotcha.
Does that make
Gotcha.
sense?
Thank you.
Okay. Sure, no worries. So I'm going to stop sharing and then I'll share again. All right, so when we're looking at our episiotomies, we talked about this. We have our redness, our discharge, and approximation. What are we doing post delivery? Sorry, you're going to make sure that you're keeping that nice and clean, no infection, no area for infection, right? No suppositories or enemas if it's 3rd or 4th degree. Remember, our 4th degree goes all the way back to the rectum. With our cesarean, we're going to look at our incision. We're going to look at redness, swelling. You're really looking for bleeding and signs of blood clot because you're increased with C-section because it's a surgery, plus you're on bed rest. All right, attachment and bonding. This is important during that bonding period. So we're going to really look to skin after birth, which means you put the baby right on the skin of the mother and look for those attachment behaviors. Look at postpartum blues, postpartum depression, postpartum psychosis, all of these that we talked about after our last test, like our baby blues, right? And we peak around 5 days and subsides by day 10. Postpartum depression is going to be that intense and persuasive sadness, and that's going to last more than 2 weeks. And then we have our psychosis, which is way, way deeper and much more compromising. All right, so we're going to teach for any of these: balanced diet, sleep when the baby sleeps, get fresh air, flexibility in your schedule, talk about your feelings, consult with physicians. And if symptoms don't work, if the symptoms worsen or do not resolve after a couple weeks, what are you going to do? You're going to meet with a provider. I apologize. The postpartum section we did do after our last test, so let's just quickly look at that. There's only 2 or 3 here. Just know where your uterus is going to be from, just sort of gauge it. It should be going down. By day 9, you're down about like right there at the pubis. So just remember that. And contractions is what makes that uterus go back to its normal size. So that's why we're going to be, should uterus be firm or boggy? You guys know this. Should it be firm or boggy?
Firm.
Firm. Good. And how do we get it firm? If it's not firm?
Massage.
Excellent. You massage it. Okay. And then, so we talked about bladder and bowel. Remember, all these body systems are being impacted because now you don't have a baby in there anymore. Our lochia we looked at, we had light, moderate. So we're going to see how much is what. We have 3 different types. Everybody should be familiar with that, right? Rubra, which is our first few days. Then we have serosa, which is our 10 to 14. And we have our alba, which is like weeks 4 to 8. And usually about week 4, you're about done with that. So that's people feel good about that. So when we look at our peripads and linens, we're going to look at the color. We're going to look at, is there clots, is there odor, and how much is too much. If you're saturating more than 1 an hour, that's too much. Okay. So postpartum bleeding, we talked about it. Vaginal, it's over 500. C-section, it's over 1,000. You're going to watch for hypovolemic shock, right? And retained placenta. That means some of the placenta is still in there. We talked about the hematomas. So you massage that fundus. You make sure that bladder is empty. You establish IV access, okay? Give fluids. Make sure you have stable vital signs and oxygenation to yourself. And then you're going to have those things that'll produce contractions to contract that uterus down, okay? So there's a lot of different factors that can be involved here. You have to really figure it out. No, please, that Hebabate, which is given for postpartum bleeding, you are not going to give because it gives bronchospasms. So it's contraindicated with our asthma, and our Methergin contraindicated with hypertension. Okay. So we're going to go past those. We did this. Attachment and bonding. All right, here's some good meds to know. Oxytocin used to induce labor and to use after postpartum bleeding. Our mag sulfate we know is a CNS depressant, for preeclamptic seizures and also for neuroprotection of a baby. Okay, calcium gluconate is our antidote if we have toxicity. Terbutaline is going to inhibit uterine activity, okay, but can cause tachycardia. So remember, terbutaline and tachycardia, two T's. We have betamethasone, which is a corticosteroid that is given IM to help with the lung maturity of the baby. What does it do though to mothers? Watch with your diabetics. Any steroid is going to increase blood sugars. Okay. Here's some more. Labetalol, which is going to be a hypertensive med. Insulin, we know, is used with our moms. Methotrexate is going to be used for tubal ectopic. And then we have Rogam for RH. And methadone, we all know, is used for our opioid addicted. All right, case study 1. Let's do this together. 28 years old, first pregnancy ended in miscarriage at 18 weeks. She's 39.2 weeks and came into the hospital. Into the hospital for spontaneous rupture of membranes. So her fetal heart tracing has moderate variability with accels and no decels. And now she's sitting there. What is her GP? Not GTPAL, just her gravida and parida on that one. I want you to put it in the chat. Okay, so what's her G and P? You guys can help on this. You're putting it in the chat. Okay. She's 28, first pregnancy ended in miscarriage, 39 weeks gestation. Good. So she's a G. She's been pregnant twice. So a G2P0 as of now. Good. One person got 0. Somebody else got 0. She hasn't delivered yet, right? Once she has this baby, she'll be a G2P1, right? Okay. What is the assessment of the fetal heart tracing? Reactive or not reactive? Moderate variability, accels, and no decels.
Looks
Is that
good.
reactive or non-reactive? You guys can call it out if you want, if that's easier.
Reactive.
Good, it's good. What are we looking at? Accels and moderate variability, right? Remember, it goes mild, minimal, moderate, and when it's too much. All right, what types of pain could you offer? Non-pharmacological. What could you give her?
Positioning,
Good. Can have her roll around in different positions. What else?
massage,
Yes, you're just gonna be careful where you're massaging, but good.
I guess guided imagery,
Sure.
Breathing technique.
Excellent. Breathing. How about some music? You could put some calming music on, right?
could you do like a warm compress to like her lower back?
You could do a warm compress to her lower back if she wants that. Yeah, sure. Just make sure it's not boiling water, you know.
Right.
All right, 2 hours later, the contractions are getting stronger. She wants an epidural. Fetal heart tracing continues to be reassuring, so we know that it's reassuring. What's a reassuring fetal heart rate number? What's our range for normal fetal heart tracing?
110 to 160.
Excellent. 110 to 160. However, after that epidural placement, the fetal heart tracing begins to show late decelerations with minimal variability. Oh no. The nurse notices that the blood pressure is 76/42. What is the first thing we do?
Will we turn
Would
her?
you turn the patient to her side?
Left side.
Which side? Yep.
Left.
Yep, because we're gonna take that pressure off the vessel that goes down the back. And what else are we gonna do to her? Her blood pressure is super low. How can we bring it up?
Fluids?
Excellent. You're going to flood her with fluids. And why is the fetal heart doing this?
Oxygen?
Core
Could be
compression.
hemorrhage.
Mm.
I don't
Now, post epidural, this is very
Oh.
commonplace.
know. Oh.
Post epidural, this is very normal. You'll have a low blood pressure. If the mother is not perfusing well, the baby isn't perfusing well. So that's why the fetal heart does that. It says, hey, I need help here. All right, so that's why that's happening. All right, now we keep
Hmm.
going. Nursing interventions are implemented and the fetal tracing is now reassuring. Good? We're good. We're back to moderate variability. The Pitocin is started and the contractions are becoming stronger and more frequent. The patient is comfortable with her epidural and her blood pressure is now within normal range. The fetal heart tracing begins to show variable decelerations that are increasing in frequency and depth. Based on the current assessment of the fetal heart tracing, the physician places an intrauterine pressure catheter. Why do you think he did this?
To gauge the contractions a little bit better.
Yeah, so what's an IUPC do? It tells you how strong those contractions are, right? 'Cause
Yes.
if you have the external one on, you can't really tell because it depends on how hard the stomach is, right? All right, and then what do you think variable means? Variable decelerations we should know is what? Why do you get variable decelerations?
Is it
that cord
squeezing the
compression?
head?
No, those are earlies.
Is that cord compression?
Yep.
Yeah.
So what's another way we could do that? We could flip her again, right? Turn her around, see if
Yeah.
that relieves the pressure on the cord. We can give her oxygen because that'll give her a little extra boost to the body. Okay, we're gonna skip that right. All right, so now the cervix is now completely dilated and the head is low in the pelvis. So she's gotten to fully dilated. So what does that mean?
She had 10 centimeters.
She's ready to
Excellent. She's ready.
push.
She's ready to push.
Yeah, first. But then they go back to the operating room emergently because of the fetal heart tracing. So they do general anesthesia because it's stat. Baby is taken out and goes to the NICU. By the next evening, the baby's out of the NICU, breastfeeding and doing great. And so we know now that there was nothing that was going on but mixed respiratory and metabolic acidosis at delivery. And that's because we saw that in the fetal heart tracing. So that was like kind of a crazy one. All right, here we have some OB math calculations. I don't really have a good way to show you guys how to do this. So let's just look at it. For when we're looking at, I don't have like a blackboard that I would do it for. So if we want to do GTTs per minute, we do mLs times our drop factor and then over how many minutes. Okay. So I'm just going to go over these real quickly. What I want you to be very familiar with is pounds to kilograms, grams to milligrams, and ounces to mLs. You're going to see intake and outtake, intake and calculating total amounts daily. All right, and this is our mag sulfate. That's a more intricate one. I want you guys to look at these when you have a chance and try to do the problems yourselves and see if you get the right answers. Okay, if you have any problems with math, I'm happy to go over that with you. But I don't think I'm going to because math is hard for me to go through. There's a Kahoot. You guys like Kahoots? Oops, at the end of this. And there's another couple questions. All right. The home nurse visits a pregnant client who has a diagnosis of preeclampsia. Which assessment indicates a worsening of preeclampsia? So I want you guys to look and then answer them in the chat. Excellent. Number 4. Why do we worry about number 4?
Because the headache and blurred vision?
Yeah, those are symptoms that we know that preeclampsia is getting worse. These are neurological symptoms that we look for. Excellent. All right, ultrasound is performed on a client who's experiencing moderate vaginal bleeding. The results of the ultrasound indicate that abruptum placenta is present. On the basis of these findings, the nurse should prepare the client for which? All right, we know when the placenta is abrupts, we know that our goal is to control the hemorrhaging and get that baby out because they're not going to be able to survive with that placenta gone. All right, teaching a pregnant person about nutrition and insulin needs during pregnancy. What do we know happens in the second half of pregnancy? Remember what requires second and third trimester, that insulin resistance is going to go up. So high demands can cause an elevation of blood glucose levels. So you're going to increase the need. You're going to need more insulin, right? Calorie and protein intake is not affected throughout pregnancy. You should have the same all the time. All right, let's look at this. Ooh, let's look at this one. 16-year-old, 36 weeks gestation, blood pressure is 130/90, swelling and mild proteinuria. Which statement by the woman should alert the nurse to the worsening of gestational hypertension? What is the only thing you see here that's not resolving? So even if you didn't know what the question was, 3 of the 4 answers are all about something that went away. All right, so your answer here, everybody got it? Excellent, should be 1 because everything else is going away. So why would she worry about it getting worse? If the swelling's gone down, heartburn was fine after she had spicy foods, that's normal, and a headache, but took some Tylenol to go away. Okay, good. You guys are doing great on these questions. I'm going to stop sharing here and ask, are there any other questions that I can cover for you guys about this test? I apologize. I forgot we did postpartum already. So all that postpartum section will be on people's tests, but it also depends on what your teacher picks. Okay, so any of this is free game for the test. Just know each class gets a different test because the professors pick the questions themselves.
When you went to the magnesium sulfate equation, is that the typical ordered dose over ml, or is it a different breakdown of the equation?
I think it's just a general.
Okay.
They'll have you practice mag sulfate because that's a very common one. That's a
Okay.
common given med. So look at your mag sulfate equations on your like calculate with confidence.
Okay.
Good question. Anything else I can help anybody with? All right, you guys have my contact info. You can always email me and ask me any questions that you have. Other than that, my class will see you Wednesday for our test. Everyone else, best of luck. And my class, best of luck to you guys. Please let me know if I can be any help.
Thank you.
Take it
Thank
easy.
you.
Mine.
You're welcome. Thank you for participating.
Thank you. Have a good night.
You're welcome. You're welcome, Shalonda. You're good?
Yes, ma'am.